during your medical student period, you could have used the term varicose veins. Okay, that's a common term used and common disease to see also. And chronic venous diseases, or in other words, varicose veins are part of chronic venous diseases. So, what are these chronic venous diseases? So, other than varicose veins, you get other things which can cause the same problems. Okay, so chronic venous diseases is a spectrum of clinical manifestation or clinical diseases occurring due to all of them occurring due to venous hypertension. Okay, so let's look at what are the other things other than varicose veins you get in chronic venous diseases. So you may have seen this. These are small veins, by definition not enough size to define as a varicose vein. So these are terminal veins. Okay, so this one you may have seen a small blue colored veins on the skin, that is called the reticular veins, and on the left side you see something like a spider veins, and again these are also part of the venous disorders. So you don't call them varicose vein, but you call them reticular veins and telangiectasia.
Sir, we can't hear you, sir.
Okay, can you hear now? Can you
Yes,
hear now?
yes,
Yeah, okay. So these are also chronic venous disorders. Okay. And this the next one is a typical one. Then these are varicose veins. So you see large dilated tortuous veins, superficial veins. You call it varicose veins. Again, it's also one of the spectrum under the chronic venous disease. Then you may see patients like enough patients like this in the clinic. Venous ulcer. Okay, and then you see all the other changes of chronic venous hypertension here. What else do you see? You see pigmentation. When you touch the skin, will be hard. Then you call it lipodermatosclerosis. And of course, you see a venous ulcer. So all these spectrum, the telangiectasia, the varicose veins, and of course edema in this leg, then pigmentation and venous ulcers all come under the term chronic venous disorder. So from today onwards, in addition to varicose vein, know that there are other chronic venous diseases. Okay, right. So there are classification for chronic venous diseases. One classification, the famous one is CEAP classification. That is a clinical, etiological, anatomy, and pathophysiology. So you can see clinically, other than the varicose veins, you get other things. So what they have said as small varicose veins are the reticular veins and the spider veins. Okay, so you get edema, you get skin changes, you get ulcerations, everything under clinical grading of chronic venous diseases, and each of the things are given a number. And etiologically, so these are things you have to find out in your short case. Okay, so you see a patient with features of chronic venous disorders, then you try to find out the etiology. Okay, so generally primary. Okay, so varicose vein, for example, is common, and you don't you generally find a secondary cause. Sometimes it could be secondary to other causes, like, so again you had to exclude in your short case history like past DVT. Okay, so what you don't want to do is to operate a dilated vein on a patient who already had a DVT. Okay, then you are going to cause trouble. Okay, it could be secondary to obstruction of the vein may be by an external compression. Okay, so those are secondaries rare. Sometimes patients come with varicose veins and other things. For example, in syndromic diseases, they come with varicose veins which are abnormal in distribution. Then they have large legs. Then they have cutaneous changes. So those are congenital. Okay, so etiology you have to find out in your short case. And anatomically, of course, superficial veins mean the varicose veins, reticular veins, and spider veins. But you can, this is what I said, you can have the same kind of presentation due to deep vein abnormalities or perforating vein abnormalities. Again, in your exam, you can find this out. And pathology on these veins often reflux. And as I mentioned earlier, if it is a DVT or something, obstruction. Okay. So CEAP classification is a comprehensive thing, but for your purpose, when you are taking short history, try to find these things out because all these things will determine the management. Right. Again, the clinical part of it. So commonly you see this in the clinic. Venous ulcer you may get for a short case. And if you get for a short case, so typical position of the venous ulcer on the gate area over the malleolus, shallow ulcer, you don't see the tendons and bones and periosteum like in other deep ulcers. So shallow ulcers and the edges are already epithelializing. So it's sloping edges. And if you look at their dressings, it's soaked. So it's oozing. Okay, and no, they may have discomfort, but no severe pain. Okay, so those are the features differentiating them from other common causes of ulcers. And why they don't heal? Some examiners may ask you why the ulcers due to chronic venous hypertension do not heal. There are various theories. So first thing itself is a venous hypertension that results in accumulation of fluid and tissue edema, and the fluids keeps on oozing, then they don't heal. And in addition to fluid oozing out through the epithelium due to various other factors like the third reason I have given, the proteins leak out the capillaries and they surround the capillaries, especially the fibrin, and they form a kind of covering over the capillaries, resulting in reduced permeation of the oxygen and nutrients. Okay, then the ulcer don't heal. Third thing is due to sluggish flow in the capillaries, the white cells get trapped. And when the white cells are trapped, they are dangerous. They get activated. And the job of the white cell usually is to destroy the bacteria and other foreign things. So when they get activated by other reasons like in sluggish flow and getting trapped, they release the same enzyme resulting in damage to the surrounding tissues and endothelium and pericapillary tissues. Again, in effect, the ulcer is not going to heal. So know these things in your short case. You may be expected to know this. Okay, right. So varicose vein I have mentioned again. So know that it is a dilated tortuous superficial veins. You don't call a deep vein varicosity. Okay, that's not a varicosity. Okay, and also it has to be tortuous. Okay, sometimes people come to show dilated veins. For example, dilated long saphenous vein. They are concerned to see whether it is varicose veins. It is a normal dilated vein. Okay, you scan them. There's no reflux. Okay, some people come with upper limb veins as well, dilated upper limb veins to see whether that's also varicosity. That's not varicosity because it's only dilated, not tortuous, not elongated. Okay, can you all hear?
Yes, sir.
Right. And how the term varicose veins came is from a Greek word. and also know the anatomy. So superficial veins and deep veins, those are two main systems. And superficial vein also know about the long saphenous vein and the short saphenous vein. So those are two things you have to describe in terms of your descriptions. Okay, long saphenous vein and short saphenous vein. Okay, if you see varicosity is mainly behind, it is in the short saphenous vein territory, but commonly you get it in the long saphenous vein territory. Okay, and perforators, of course, you won't see, but you can feel the exit point of perforators in the fascia if they are enlarged. Okay, right. And perforators also exist at certain points. So concentrated in certain points, mainly below knee, mainly around the ankle joints. Ankle joint, you call it a pocket perforators. So you see people who has prominent veins at the ankle joint, and above that is pretty normal. But you have, of course, perforators in the other areas. You have in the below knee area, and you have in the thigh area. Sometimes these perforators may connect with the saphenous vein, and the varicosity start from there onwards instead of the main SF junction. Right. So history, I said short history. So for your purpose, it's about the CEAP classification, and at the end of the examination, the definitive question is, what are you going to do? Okay. So to find out what intervention you are going to offer, you have to know certain things: the venous territory, the cause of the varicose vein, and what the patient wants. Okay. So if the cause is obstruction, then you don't want to treat the superficial veins and destroy that. Okay, because it is when the deep veins are obstructed, it is a superficial vein which is helping. Okay, and what the patient wants also. So why I am saying it is varicose veins are common. Okay, if you take all the patients, about 20% of them are going to have varicose veins, but not all of them want a treatment. Okay, so find it out from the patient, but there are specific indications for intervention as well. So if those are there, then again the patient's preference also matters. But medically there's indication. Okay, right. And on inspection, patients should stand. Okay, then only the vein dilates. Then only you get a proper distribution of the varicose veins. And expose, so well above the knee joint. Okay, and then describe. Okay, I would suggest that you give a live commentary and describe whether it is in the long saphenous vein territory, whether it is in the short saphenous vein territory, above knee, below knee. Describe those things. Look from front and look from behind as well. And edema, feel and confirm. Skin changes, describe. And there are various other tests which we may or may not do, because the reason is these days we have ultrasound scan which will detect all these special test findings. Okay, for example, tapping test, we will come to that, and again tourniquet test. Okay, so tapping test confirms reflux. Okay, so what it means is, you usually in normal veins, if you tap distally and feel proximally, you are going to feel the tap. Okay, that's normal because blood flow direction is this, and the tap is also going to go that way. Okay, that's normal. But if you reverse the tapping, so tap above and feel below. So when you are tapping above, if you could feel in this spot, it is abnormal. Okay, because blood is not supposed to travel this way in the lower limb veins. Okay, did you all get that? Did you all get that?
Yes.
Right. So that's a tapping test. And then there's a special test called tourniquet test. Okay, again you all ask, how many tourniquets you had to take and how many times you had to apply. I'm sure the people who are listening now also has the same question, isn't it? So how many tourniquets and how many times? Don't you all have that question? Do you all have that?
Yes, sir. Yeah.
Yeah. So then the question answer to that is you can take any number of tourniquets and you can repeat it any number of time. Okay. Because interpretation depends on what you find and not what you expect to find. Okay. So let's see how it is done. Okay. Again, these tests are not done these days. All these findings you can find easily with an ultrasound scan. Okay. So what you do is get the patient to now all this time the patient has been standing. Is that clear in your examination? Okay. This patient has been standing all this time. Now get him onto the bed. Okay. And then raise the leg and empty the veins. Okay. So how many tourniquets? Any number. So generally I would advise you to take 3 tourniquets. And where do you apply? Again depends on what you found when the patient was standing. If the patient was standing, when the patient was standing, if the varicosities were mainly below knee, then you don't go and apply 2 out of 3 tourniquets on the thigh. Okay, no point. Okay. So generally what I would suggest is apply 1 in the mid leg, 1 below knee and 1 in the mid thigh. Okay. And so apply the tourniquet while the leg is raised. So you have to of course get the help of the examiner to keep the leg elevated. Okay. Now ask the patient to stand. Okay, now is the important part of your examination. Ask the patient to stand and observe under good light. Okay. If there is a sudden feeling, okay, sudden feeling means less than 20 seconds or within 20 seconds. If within 20 seconds one segment is filled, that is abnormal. Okay, that is abnormal. That indicates either a perforator or the truncal vein is incompetent, okay, or refluxing. Is that clear for you all? Okay, so you observe for 20 seconds and if something happens within that, it's abnormal. Okay, there's something wrong between your tourniquets. Okay, is that clear?
Yes.
Right. Now, suppose this patient stood up and suddenly you see there are 2 segments filled. Okay, despite having tourniquet. One is this and another one is this. So what do you all can tell? You can tell the perforators in this region is refluxing. Okay, and also the long vein is refluxing. Okay, in this case, of course, saphenous vein. In between tourniquet 1 and 2. Okay, is that clear? That's all you can tell. Okay, either the perforator or perforator plus the long saphenous vein is refluxing in between these 2 tourniquets. Is that clear?
Yes, sir.
Right. And below also it got filled. Again, you tell the same thing. Either a perforator, looks like most probably perforator. I don't see the long saphenous here. So a perforator is refluxing below this tourniquet. Okay, is that clear?
Yes,
Is
sir.
that clear? Okay, now the patient is standing. Now in this patient, of course, now removing the tourniquet will not provide any more information. What's the reason? What's the reason? Now no point removing tourniquets in this patient now. Why?
Because already the lower leg.
Yeah, because the segments are already filled. But suppose these segments were free of blood, then you start removing the tourniquet from up downwards. Suppose this was empty, no veins here, and you remove the first tourniquet, and suddenly you see within 20 seconds it all got filled like this. Then what can you tell? Then you can tell the long saphenous vein above was refluxing and it has come down. Okay, is that clear?
Yes, sir.
Right. So if it is filled, you can. Again, this lower segment also you can't interpret because it's already filled. But if it is not, and then you remove and it gets filled, means again the long saphenous vein in that above that area was incompetent and it's getting filled. Okay. That's what you can tell. Okay. So that is why I said the interpretation depends on what you are going to see. Okay. And interpret it as you wish. Is that clear now? Tourniquet test?
Yes, sir.
Right. So that's nothing to worry. How many tourniquets and how many times you can decide. But I would suggest take 3 tourniquets and do it only for one time. If at all you are asked to do. Okay. Generally the cases you are not going to be requested. Okay, because time is not enough. Right. So all these findings and the etiology and the pathology could be demonstrated with this machine. What is this machine? This is an ultrasound machine with Doppler. Okay, so duplex scan. Okay, ultrasound with Doppler. Okay, have you all seen this machine? Have you all seen this duplex machine?
Yes, sir.
Yes. So if you happen to see a modern ultrasound, I am sure that's a duplex. Okay, every ultrasound machine has a duplex. The Doppler information. Okay. Okay, then you can detect all these things which we are struggling to demonstrate all this time. So you can detect the reflux, you can guess the presence of obstruction, and you can find where the problem is, and therefore you can plan the intervention. Okay, right. And there are so many other tests which you don't do in all the patients. But suppose there was a category called congenital. Okay, for something like that. Or if you suspect an iliac vein thrombosis, or if you suspect an iliac vein obstruction, then you do some additional test other than duplex. So what we do is usually a venography, okay? A CT venography. All the other tests are not usually done, okay? Right. Right. So duplex scan, you can demonstrate all these things. And you may not want to know the position, but this is how it is done. And this is how you see a great trunk. Okay, so you see the vein as a dark circle, and you see fascial layers on either side which appears as an eye. You don't need to know this. And this is how you see the SF junction. Again, you need not know this. And this is how we detect the reflux. Okay, so we keep the Doppler over the vein and squeeze the cuff. Okay, when you squeeze the cuff, the flow within the saphenous vein is enhanced. And when you release the cuff, if there was a reflux, it will flow in the other direction. Then we demonstrate reflux. Now look at this. So you keep the Doppler over the vein. So the Doppler gate is here. You can't see that the Doppler gate must be here over the vein. Okay. And squeeze the cuff, you get a increased flow in the vein. Okay. So that means augmented flow. Okay. And when you release the cuff, if there was a reflux, there will be a backflow. So this is a forward flow and there's a backflow. Okay. So this vein has a reflux. Okay. That is how you demonstrate. In color also you can see there's a forward flow one color and backward flow one color. Okay. So there's a reflux here. Okay. Now these are the indications you have to find out in your history. Okay. Whether the patient is concerned, what we call a cosmetic concern. Okay. So usually don't tell, I mean, it may sound funny. So the elderly people are concerned having varicose vein, not because they are cosmetically concerned. They are concerned whether it will increase in size, whether that will bleed, that kind of concern, okay? And symptomatic, of course, you intervene. So pain while standing for a long time and presence of varicose vein, you intervene, okay? complicated, C3 downwards. Okay, edema, skin change, healed and active ulcer, you treat. So these are the only indications for treatment. That's what I told. Find out whether these are there. Okay. All the other patients you don't treat. Otherwise, you will end up doing thousands of surgeries. Okay. Right. So what are the options available? You have the old style surgery. Okay. Some of your relatives may have had saphenofemoral junction ligation, stripping, avulsions, those kind of things. Surgery. Okay. And nowadays you have less invasive thermal ablation methods. So we use the laser energy derived heat. Okay. These days. And some of your relatives may have had only injections. Okay, what they call injection is, in our term, it is sclerotherapy. Okay, so let's see who gets who, what. So in those days, they get surgery. Now they get thermal ablation. If they don't have any indication for thermal ablation, then they get sclerotherapy. Let's look at this. Okay. So generally, general principle is, in this slide, if a patient has SFI or SPI, and if the patient has long saphenous vein reflux, that vein needs to come out. Okay, so then they need a laser energy to ablate the long saphenous vein. Okay, so when you use laser, of course, you don't talk about the SF junction, because if you ablate the all the length of the saphenous vein, there's not going to be a SF junction. Okay. So general principle is, if there's an SF incompetence plus long saphenous vein reflux, you ablate the vein. Okay, is that clear? So nowadays you talk about laser. Okay, earlier surgical ablations method were there. Okay, is that clear?
Yes.
Yes, sir.
Right. But if they have only branch vein varicosities, below knee varicosities, perforating incompetence, then you offer sclerotherapy. Okay, is that clear? Is that clear? So simply two indications. Okay,
Yes, sir.
right. And how do you do this question? Of course, some surgeons may ask. So varicose vein surgeries, you put the patient on Trendelenburg position. Okay, to empty the veins. Therefore, bleeding is less, and the effectiveness of even thermal ablation is better. Okay, right. And for medical students, SF junction and what are the branches draining into the saphenofemoral junction or close to the saphenofemoral junction, people may ask. So remember, at the SF junction, the femoral vein do not get tributaries, and it is a saphenous vein which get tributaries. Okay, so just remember that for a nice to know point. Okay, right. So old style stripping, and you use a stripper to strip. We don't do it anymore. And laser. Okay, so what does laser means? That's an acronym for this: light amplification by stimulated emission of radiation. Okay, so this is a laser machine which creates laser energy. It is transmitted through this fiber which is placed inside the vein, and we do it under ultrasound guidance, and the tip will generate heat. Therefore the vein is burned and ablated. Okay, so that is how the laser works. Sclerotherapy, we use various irritants. So what happens is, they irritate the venous wall, create an inflammation, therefore they adhere thrombus and disappear. Okay. So if you come to our ward, or if you encounter a diagnosis card, sometimes you see foam sclerotherapy, foam. Because we take this sclerosant, we use STD. Okay, that's another common question for a medical student. So we use STD and mix it with air and make it into a physical form. that is injected into the vein. So that is why we call it foam sclerotherapy. Okay, right. And this one for venous ulceration, the mainstay of treatment is multi-layer compression dressing. Okay, what we call as strapping. Again, common question is how many layers and what are the layers, isn't it? So common question is you are going to ask how many layers you are going to apply and what are the layers you are going to use. So the purpose is multi-layer compression stocking. So what we usually use is a dressing over the wound, a cotton wool layer, and a crepe bandage layer. So what we generally end up in our strapping clinic, therefore we only use 2 layers. Okay, but commercially made ones. So on top of the cotton wool crepe, you get a self-adhesive bandages, what is called a cohesive bandage. And on top of that, you can put adhesive bandage. They are for 4 layers, but in our strapping clinic, we usually put 2 or 3 layers. Okay, those are cotton wool, crepe, and sometimes elastoplaster, but usually cotton wool and crepe. Okay, is that clear? Okay, is that clear?
Yes, sir.
Why do we call it a graduated compression? Any idea? And why do we compress? So I started by saying these are diseases as a result of venous hypertension. Okay, so we are counteracting venous hypertension. Now tell me why it is graduated compression and what do you mean by that? Anybody?
So the pressure of the bandage increases from down upwards.
Yeah, that is a graduated compression, correct. And that is aimed at? Yes,
Aimed
correct.
at targeting the venous hypertension, that is
Yeah,
because
so
the highest pressure is lower.
Yeah, correct. Aimed at facilitating venous drainage. Okay. Okay.
Okay, sir.
Yeah. Then, yeah, how many layers? Of course, in this picture, I have shown only 2 layers. Okay. Is that clear for you all? So, if you ask a patient to buy a commercially available one, you can apply all 4 layers. Anyway, by the way, why do you want to apply in layers rather than a single bandage? So, all the other patients who come to the wound clinic get a single layer. Why only these patients get multiple layers? Any idea? Any idea? Can you all hear?
We can hear you, sir.
Yeah. So, any idea? So, all the other patients to the wound clinic gets 1 layer or 2. Yeah, generally 1 layer. Why these patients are getting 2 layers? At least 2 layers. Why?
Otherwise, we would not be able to exert the needed pressure, sir.
Yeah, correct. If you take a crepe bandage and apply it under high pressure, the next visit patient is going to have additional ulcers due to pressure and injury caused by the crepe bandage. Okay, that's why you apply multiple bandages to make it comfortable and effective. Okay, is it clear again?
Yes, sir.
Yeah. Okay. Okay. Are there any questions? Are there any questions?
So when doing the tourniquet test, the
Yes.
veins below the lowest tourniquet,
Yes.
can't we think that they fill because of the blood that comes through the capillary bed up to the veins?
Yes. So if it has happened after 20 seconds, yes.
Yes.
But if it happens within 20 seconds, something wrong. Okay.
Understood.
Something. Yeah. Right. Any other questions? So, yeah, your question, if you wait long enough, if you leave the patient and plaque some other patient and come back, of course, you can't interpret anything at all. Okay, because that's going to be a normal phenomenon. Okay. Yeah.
Excuse me, sir.
Yeah.
Can be there recurrences of varicose after the surgery or ablation of the whole length of the vein?
Yes, there can be. So recurrence, there are various reasons. Sometimes in the old style, you don't strip the vein, then that can connect to the SF junction with the collaterals and form the same problem. Okay, so when you don't strip, sometimes when in lasers, when you do lasers, they can recanalize. Okay, sometimes you can treat the proper vein and accessory veins come up. So for these reasons, it can recur. Okay.
Okay, sir. Thank you.
Yeah. Recurrence is also not rare. Okay, for these reasons. Or sometimes it could be another territory. You do it on the long saphenous and the short saphenous vein comes. Okay.
Okay, sir.
Yeah.
Sir, what are the options for wound cleaning in the venous ulcer?
Yes. So in chronic ulcers,